living with cancer as a chronic disease. Oops, sorry. Those who are living with cancer as a chronic disease with a recurrence or a metastatic disease, even those who have a terminal illness or who are at the end of life are still considered cancer survivors. So it just kind of creates this complex situation. It's sort of the best word we have, cancer survivors. Not everybody loves the word survivor, but it's sort of the best we have. So we're going to go with that term for now. But you can see it's a complex definition. So let me turn to some trends in cancer incidence and prevalence that highlight why we focus on cancer survivors now. So the first trend I want to talk about is increasing incidence of cancer. So I don't mean incidence rates here. What I'm talking about here is the absolute number of people who are diagnosed each year with cancer. So that you can see back in the year 2000, about 1.3 million new cases of cancer were diagnosed in that year. And that number is expected to double, 100% increase by the year 2050. So by the year 2050, we expect to have 2.5 million new cases of cancer diagnosed in that year. Why is this happening? Does this mean that cancer rates are increasing or that cancer incidence rates are increasing? Actually, no. This is the result of several factors. First, the US population is growing exponentially. So there's just more people. So we get more people diagnosed with cancer. And the fastest growing segment of that growing US population is those over the age of 65, when cancer predominantly is diagnosed. So we have more people and more older people. And we also see that people are dying of less of other causes. So heart disease and other, accidents and infectious disease rates of death from those causes are decreasing. So we have more people alive and more people sort of available, if you will, to get diagnosed with cancer. So that's why we see these numbers of people being diagnosed each year increasing. So that's sort of the bad news. The good news is that if we look at incidence rates, which is the percentage of people in the US who are diagnosed each year, we see a different story. What we see here is that for males, incidence rates are going down and quite notably. And for females, they're kind of holding steady or maybe slightly increasing. And this really varies by cancer type. So these are just combining all cancers together. But generally, we see that incidence rates are tending to go down over time. So that's good news. We also see, and this is sort of the second important trend here, is mortality rates are declining. And so we see that fewer people are dying of cancer over time. And why do we think that is? So it's jumping around here. So this is primarily because we have better treatments. And so we can keep people alive longer. We have better early detection methods and more people are engaging in cancer screening. So we can catch cancers earlier when they're more treatable and more curable. And that people are engaging in healthier behavior. So we see rates of smoking going down and things like that. So we're seeing fewer people dying of cancer over time. Okay, let's see if I can get this to advance. Okay, so another trend that I want to talk about is trends in survival rates. So what we see here is back in the 1950s, about a third of the people diagnosed with cancer lived 5 or more years after their diagnosis. By 1970, about half of the people diagnosed with cancer lived 5 or more years. And now we see more than 2/3 of people diagnosed with cancer are still alive 5 years after their treatment. Again, this is due to improved treatments, targeted therapies, more effective regimens, and better methods of early detection. So what do these trends lead to? The first trend was more people being diagnosed, that increasing absolute incidence each year. And if you combine that with the second trend, decreasing mortality rates, fewer people dying of cancer, and more people living with their disease 5 or more years, what you get is increasing number of cancer survivors. In other words, prevalence. And if you look at this chart, what you see reflects that. What you see back in 1975, we had about 3.5 million cancer survivors in the United States. In 2019, around 17 million. Right now, it's about 19 million. And by 2040, we expect that number to increase to more than 25 million cancer survivors in the United States. So that's an exponential growth. in the number of people living with a history of cancer in the US. And this data mirrors what we see internationally as well. And you can see that the fastest growing segments of those populations of cancer survivors are those over the age of 65. So we have more older people living with cancer nowadays. What about in the state of Maine? Sorry. Well, Maine has some of the highest incidence rates, cancer incidence rates, and mortality rates in the country. And cancer has now become the leading cause of death in the state of Maine. So yes, those are trends that are unfortunate, but they're consistent with what we see in the country in terms of increasing number of people diagnosed and increasing people surviving the cancer. So there's more cancer survivors in the state of Maine. So if we think about this growing population, exponentially growing, it's going to be 20-something million in a couple of years of cancer survivors. There's an increasing focus on their quality of life. Whereas before, we were just focused on treatment and trying to cure people. We're now focused on how are people doing after they survive their illness. And when we think about quality of life, we tend to break it into these four major domains: physical well-being, psychological, social, and spiritual well-being. And you can see some of the important issues in each of those domains. So in the physical space, we're looking at pain, fertility, how people are functioning, fatigue and sleep, and overall physical health. Psychological, anxiety, depression, worries about recurrence, and cognition or attention. Social is really how people are doing in their roles, in their family, and at work. And then spiritual is making meaning of their illness, often religiosity and spirituality, hope, and uncertainty about the future. So those are kind of the major domains. Here's a list of common survivorship care concerns that patients report or survivors report. So again, it's kind of the same things you just saw: pain, fatigue. We see emotional issues, depression, anxiety. We see a lot of people report cognitive changes, problems with memory, concentration, commonly referred to as chemo brain, lymphedema, swelling in the arms and legs. We also see many women forced into premature menopause, treatment-induced ovarian failure due to chemotherapy, which causes a number of menopausal symptoms. And in both men and women, we see sexual dysfunction from various treatments and body image concerns. So these are some of the major issues that cancer survivors are continuing to experience even after their treatment is completed. So what about research on cancer survivors? So back when I started doing this research about 25 years ago, 30 years ago, most of the research in this space was primarily descriptive, and it was cross-sectional. So we really didn't know how people changed over time. We could take a snapshot of how they were doing at that time, but we didn't know what was the sort of trajectory of functioning, quality of life over time. We needed more longitudinal studies. We also the research tended to focus on people who were very close to their diagnosis, within 5 years of their diagnosis. So we didn't know very much about long-term cancer survivors, and we had very little research on caregivers of cancer survivors. Most of the research focused on a single cancer. Most studies were a single cancer, and most of those studies were either on breast, prostate, or lung cancer. So we really didn't know that much about survivors of other types of cancers, especially the rare cancers. Also, most of this research was really consisted mostly of the people who were treated at the elite cancer centers who got the big grants to do survivorship research. And so we had mostly Caucasian individuals, poor representation of non-white or younger cancer survivors. And most of these studies were relatively small in terms of their sample size. They had limited statistical power. So we didn't really know how well they represented or generalizable to the larger population of cancer survivors. So what do we do about that? So while I was at the American Cancer Society, where I worked for nearly 20 years, we launched a program of research called the ACS Studies of Cancer Survivors, or SES. And this program of research included 3 different distinct projects. SES-1, or Study of Cancer Survivors 1, used a prospective longitudinal design in which we enrolled a cohort of over 6,000 cancer survivors of any one of 10 different cancers. And we followed that group for 10 years. And we assessed them at several time points along the way, looking at their quality of life and health behaviors. But that study didn't allow us to get to long-term survivorship issues right away. We would have to wait till that cohort reached long-term survivorship to know about that. So we designed a second component, which we called SES2, which used a cross-sectional design in which we enrolled 3 separate cohorts of people who were either short, medium, or long-term survivors. So roughly 2, 5, and 10-year survivors of any one of 6 cancers. And that gave us data on long-term survivors without having to wait for the longitudinal cohort to reach maturity. We also wanted to know about caregivers. So we asked the individuals who agreed to participate in the longitudinal study to nominate their primary informal caregiver, usually a spouse or a first-degree offspring. And then we enrolled them in a separate study, enrolled around 1,600 of them, and basically did a study of cancer caregivers as well. And that allowed us to have dyadic data between survivors and caregivers because we use some of the same measures. So in the interest of time, I'm not going to go through all the methods, but basically these were very large-scale, nationwide, population-based studies. Overall, between the 2 survivor studies, we enrolled more than 15,000 cancer survivors and over 15,000 survivors, 1,500 caregivers. We sampled cases from 21 different states using state cancer registries. This was population-based since we sampled from SEER and NPCR registries. And as I mentioned, the major outcomes were sort of quality of life, physical and mental functioning, and lifestyle and health behaviors. Here you see the 21 states from which we enrolled, including Maine. So we started off with around 62,000 cases that we sampled. We ended up with about 15,000 cancer survivors enrolled. That's an overall, so after removing deceased and ineligibles, that's an overall yield of about 35%. When we look at the demographics, what we see on this, so this slide actually combines all 15,000, the 6,000 from SES1, the longitudinal study, with the roughly 10,000, 9,000 from SES2, the cross-sectional study, into one demographic slide. Sorry, let me back up here. Whoops. Medical characteristics, sorry. Can't tell what slide I'm on because I got 2 screens going here. So what you can see is these are the breakdown by cancer type. You can see that we sampled along incidence rates, so we have more breast, prostate, and colorectal, but still pretty good representation of rarer cancers. You can see the breakdown by the 1-year post-diagnosis longitudinal and the cross-sectional study, and you can see the breakdown by stage. So mostly localized cancer. Looking at demographics, the majority of the participants were female, but good representation of males. Most were married, good representation of younger individuals because we oversampled younger cases. Good representation of less well-educated and minority status and lower income individuals as well. And you can also see the breakdown by comorbidities. Most had surgery, about half had either chemotherapy, radiation, or both. And the majority of the people who participated were cancer-free. Around 20% had a recurrence or a metastatic disease during the study. This is the sort of timeline for data collection for the longitudinal study. So we enrolled people when they were about 1.5 years after diagnosis, around 5,900 of them. The second survey was administered around 2.5 years after that. And you can see that we had an 87% retention rate. And the third survey was administered around 9 years post-diagnosis. And again, a 61% retention rate, which is pretty respectable. So let's turn to some of the results. So the first result I want to talk about is just what are their biggest problems? What did cancer survivors tell us they were dealing with? And these are data from something called the Cancer Problems and Living Scale, which is a measure of 28 different problems. And what you see here, and I've combined the data from the 1-year survivors with the 2, 5, and 10-year survivors to give an overall top 5 problems for the sample overall. And what you can see here is that these are the items rated, the top 5 items in terms of moderate to severe problems. And each of these top 5 were rated as moderate to severe by more than 50% of the participants in our study. And if you look closely at the items, what you really see are 2 kind of themes emerging. The first is a sort of cancer-related anxiety, which we refer to as fear of cancer recurrence. And then the second major theme is a fatigue or sleep problem, problems with sleep and fatigue. When we look at these same, when we look at these same data across the different cohorts, what we see is that, not surprising, the biggest problems we see are in the people closest to diagnosis. So these are probably still treatment-related effects, but we also say that these problems don't go away. We see that even 5, 5, and 10 years after diagnosis, people are still reporting problems with concerns about relapse and problems with sleep and fatigue. Some of that may be age-related. We're not really sure because we don't have a control group in this study, but you can see that these problems are quite persistent. So let me turn to some findings around tobacco use. So this slide represents just those survivors in the longitudinal study. These are data from when they were 9 years post-diagnosis. And what's interesting about this study is that you see that the current smokers are that red bar at the bottom. And if you average that across, you see that's about 11% of cancer survivors smoking. That's relatively good because at the time these data were collected, about 19% of the US population were smokers. But still concerning that 11% of cancer survivors are still smoking. And not surprisingly, what we see is that the highest rates of current smokers are in those cancers associated with smoking. So lung and bladder cancer are the two that are most associated with smoking. And those are where we see the highest rates of continued smokers, reflecting how difficult it is to quit. Let's turn to some lifestyle behaviors. I know I'm moving through this fast, but I'm trying to get to the point where we can have some Q&A. So lifestyle behaviors. So these data represent the percentage of survivors in the cross-sectional study. So the 2, 5, and 10-year people combined, and across the 6 cancers that were in that study, who were meeting the ACS recommendations around eating fruits and vegetables, physical activity, and smoking. And what you see is kind of a good news, bad news story here. The good news is that, upwards of 90%, the vast majority are not smoking. However, the bad news is that less than 20% are meeting dietary recommendations and less than half are meeting physical activity recommendations. So there's clear implications for lifestyle interventions here. What I've done with this data now is actually looked at those people who are meeting those recommendations and looked at the relationship between meeting lifestyle recommendations and quality of life. So these bars represent the average quality of life scores. So on the far left, in that sort of light blue color, are the people who were not meeting any of the lifestyle recommendations. And on the far right, in that sort of green color, are those who are meeting all 3 recommendations. And clearly what you see is that those who meet all 3 lifestyle recommendations have better overall quality of life than do those who are meeting none. And there's actually what looks to be a cumulative effect. So the healthier you live, the better your overall quality of life. And you can see that those who are meeting 2 or 3 of those recommendations actually have quality of life that is better than the average US population on this measure, which is a very standardized measure. It's called the SF36. So clearly, meeting these lifestyle recommendations not only affects your physical health, but can improve overall quality of life as well. We also asked survivors about their problems in terms of obtaining information. And so what you see on this slide is that more than a third of the participants said they needed information in each of these areas. And in some cases, almost half of the cancer survivors indicated needing certain types of information, such as information about long-term and late effects. In addition, we found that about a quarter to a third of the survivors identified specific barriers to getting the information that they needed, including not knowing where to get the information, needing to expend great effort to get the information, or getting information that was not easily understood. And then when we asked patients and survivors about their interactions with their doctor, the vast majority said their doctors did discuss these issues with them. That's good. However, we also note that almost half report that their doctors did not provide clear instructions regarding symptoms and side effects, and more than 30% said their doctors did not provide enough emotional support. Okay, so let me now turn to a couple of closing slides around future directions for cancer survivorship research. So the first future direction for cancer survivorship research is, how are we going to care for this growing population? We know we have a shortage of providers in the United States, not only in oncology, but in all healthcare providers. So how do we care for these cancer survivors? They can't stay with the oncologist. Can they go to primary care? Should it be specialty care? How are we going to pay for that? We need research on how to find optimal models, provide optimal models for providing survivorship care. We also need to move beyond the psychosocial stuff and really try to understand the mechanistic factors in terms of biological pathways to good versus bad survivorship. Who does well, who does not do well, and why? And what are the biological as well as psychosocial issues there? We need better and stronger designs. We need more longitudinal studies. One of the limitations of survivorship research is we enroll them after they have cancer. So we really don't know what their quality of life was before they had cancer. People come to the table with anxiety, depression, issues that affect their psychosocial health. Having data about how they were doing prior to their diagnosis would really inform our understanding of the impact of cancer on quality of life. And we need greater diversity in the samples and well-matched control groups to really also understand the impact of cancer on quality of life. We also need greater focus on disparities within cancer survivors. So understanding subgroup and individual differences within cancer. You can't just generalize. There's not a one size fits all. So we need to understand those differences. And we really need an increasing focus on geriatric oncology or aging. Focusing on health behaviors and wellness is important. We need more research on the implementation of evidence-based interventions. What's the right dosage in terms of these interventions? And we also know that health behaviors don't occur in a vacuum. So if you do an intervention to improve diet, you also want to address weight management, exercise, and smoking. And then moving really finally towards dissemination, implementation, and innovation. And what I mean by that is we already know how to change health behaviors. We can do that. What we need to do now is get those evidence-based interventions out into the real world and understand how do they work in real world settings and how can we make them sustainable. Changing health behavior is not that hard. Maintaining health behavior changes is hard. And of course, incorporating new technologies, e-health, m-health, and delivering interventions. So I will stop there and see if we have some time for questions. Leave you with this take-home message, which is from a colleague of mine: a survivor may be disease-free, but they are never free of their disease, which I really think captures the essence of what it's like to be a cancer survivor.
Awesome. Thank you, Kevin. We might have time for one quick question, although I don't want to shortchange the case. So I think what we might do, unless anybody has, why don't I invite people, if there's any questions, put them in the chat. And we can, does anyone have a 1 minute or less question? I'm thinking probably not. All right, let's move to the